Hi, I'm Josh Mailman. I'm the COO of Warmth, and I'm here today on December 1st bringing a breaking news from the FDA that just today an NDA was approved for gallium-68 PSMA 11. The NDA was applied for jointly by UCSF and UCLA. And we're fortunate enough to have Dr. Thomas Hope from UCSF with us to discuss this really milestone in the United States at the very least, but maybe around the world as far as one of the first gallium-68 PSMA 11 approvals. So, Dr. Hope, do you want to talk to us a little bit about what this NDA covers?
Great. Yeah. Thank you, Josh. It's fun to be talking about prostate cancer with you instead of neuroendocrine tumor. So over the last 5 years, we've been working to get approval of this drug, PSMA 11, which is a non-patented, non-company sponsored drug. And in collaboration with UCLA over that period of time, we've ran prospective trials at initial staging and biochemical recurrence. And we were incredibly fortunate to successfully get a drug approved with the FDA in both initial staging and biochemical recurrence. So it's actually the first PET imaging agent approved in prostate cancer at initial staging. And the competitor, which would be fluciclovine, is also available in biochemical recurrence. But as we know, those who've used this drug in clinical practice, PSMA 11 functions pretty well and seems to outperform fluciclovine for the detection of metastatic disease. So we're very excited to have actually all these years of work have it paid off and finally have a drug approved.
And I know one of the things that you worked on and talked about and probably worked with the University of Iowa on was also cyclotron-generated gallium-68. You want to talk a little bit about that, although I know it's not applicable to everyone, doesn't have a cyclotron sitting under one of their buildings.
Yeah, well, that's a great question. So the NDA out of UCSF includes cyclotron-produced gallium using the same targetry that the University of Iowa included with their gallium DOTA-tox submission. So I don't know if everyone's aware, but the FDA recently approved cyclotron-produced gallium DOTA-tox, I would say like 2 weeks ago or something like that. And our NDA, although we haven't really talked about that in our approval, because I think most people are just focused on the fact that PSMA 11 is approved, but also our NDA included chemistry with cyclotron production as well. Iowa, particularly David Dick and John Sutherland, helped out a lot, as well as other people from the Mayo Clinic and University of Michigan, who were very helpful in helping us set up our cyclotron targetry, as well as General Electric, who really actually came to the plate, flew out to help prepare us for our FDA inspections and everything. So we'll see if we end up with a gallium shortage, as we've all been concerned about, with an approval of a PSMA PET radio tracer that uses gallium. It's potentially possible that the demand for generators is going to potentially go through the roof and be a limiting factor. So it's possible that this cyclotron production will be really critical for sites that have a generator to be able to make the gallium.
And I know both of these NDAs were actually pretty site-specific to UCSF and UCLA. How does this work forward for others who are interested in building off of this work?
Yeah, so this is going to be a very US-centric response. So in the United States, what happens is this approval is for manufacturing. It's a manufacturing site-specific approval. So the FDA approves a manufacturing site. And so that's why there's 2 NDAs that were approved, one for manufacturing at UCLA, and then the other for manufacturing at UCSF. But the approvals were both done as non-proprietary approvals, which means that anyone can reference that NDA. So companies, so kit manufacturers, and there's companies out there like Telix and GE and other companies that are making kits with this same drug, they can submit an ANDA or CNDA, as it might be, for a chemistry modification to an ANDA and get those approved and then distribute the kits. Other universities or centers that have radiopharmacies can actually submit ANDAs themselves and make it in-house. And also radiopharmaceutical distributors such as PetNet or Sophie can also get an ANDA to distribute the drug. It will take probably over a year for all of these types of paperworks to get through the FDA to make it more widely available in the United States. But this approval, in essence, starts that clock. So now that the FDA has approved this, then all of these other participants in the marketplace can start the clock of getting approval so that it can become much more widely available.
I have two more questions for you real quickly. And again, thank you for doing this on the day that this news broke. One is, I know that this is part of the trials that you've done for imaging. Do you want to discuss a little bit about the trials that you and UCLA worked on to have the background data for the approval?
Yeah, so the trials that we ran, and they're not earth-shattering designs. I think we changed. It's actually an interesting process. When we started doing this in 2016, we worked with the FDA very, very closely to design trials in both initial staging and biochemical recurrence. In the initial staging setting, the primary endpoint is, not surprisingly, pelvic node detection compared to pathology at prostatectomy and radical lymph node dissection. Well, not radical lymph node dissection. Anyways, so the idea is to have pathology comparison to the imaging and have a one-to-one comparison for sensitivity and specificity. So that was a trial we ran, and it's currently under review, so hopefully it gets accepted at the journal it's at. And that was done with 277 patients who underwent radical prostatectomy, and we had something like 600 to 700 patients fully enrolled, but not all of them ended up getting surgery. And actually, that trial design has now become a template for multiple company-sponsored trials in this space moving forward. So it's been good to see that this academic collaboration with the FDA has created sort of a template for how these trials should be designed. And the same thing went with our biochemical recurrence study. The hard thing in biochemical recurrence, particularly in patients with low PSAs, where it's really clinically relevant to detect these sites of metastatic disease, you don't get pathology in those patients, right? Because usually the sites of metastases are so subtle or small, you can't get a needle into it. We worked with the FDA to create a composite endpoint of imaging, changes over time, size changes, response to external beam radiation. We call it a composite endpoint to determine true positive versus false positive disease on the PSMA PET. And so that was actually published in 2019 in JAMA Oncology, our phase 3 trial looking at PSMA 11 PET in biochemical recurrence.
And the last question I have to ask, because being a neuroendocrine tumor patient, is a lot of this was done with technology or techniques that you may have learned or with working with neuroendocrine tumor patients. Can you say how that worked and how working with one disease area helped you in another, and how these things can really synergistically work together?
Yeah, I mean, that's absolutely right. So, back in 2013, we got our first gallium generator, and that gallium generator was to support our gallium DOTATOC program. We bought that with the intention, and it actually helped build all of the neuroendocrine tumor program at UCSF. Not all of it, that's a misstatement for sure, but it helped build our imaging and theranostic program at UCSF in neuroendocrines. But that availability of the synthesis module that we had, as well as that generator, directly led into our ability to label gallium PSMA 11 for prostate cancer. And without having all that chemistry expertise and the resources that was put into place for neuroendocrine tumors, we probably wouldn't have been so easily successful to translate directly into prostate. So actually, I would say one of the reasons why UCSF got into the game of prostate cancer was solely because of the fact we were so engaged and interested in neuroendocrine tumors. And you're absolutely right. This idea of theranostics, which has been fully played out now in the neuroendocrine tumor, is now starting to play itself out in prostate cancer. First now with PSMA 11, which is obviously akin to dotatate or DOTATOC, somatostatin receptor PET imaging, but also there's the phase 3 trial, VISION trial of lutetium PSMA 617, akin obviously to lutetium dotatate. And so the pairing and the imaging is very similar, the approach is similar, and so the experience we have in one disease is directly impacting the way we're practicing and impacting patients now with prostate cancer in the United States.
Well, again, thank you for sharing this this wonderful day with us and with the rest of our conference attendees. So thank you very much, Dr. Hope.
Great. Thank you so much, Josh, for the opportunity to talk, and have a great afternoon or wherever it is when this will be watched.
It's going to be morning, afternoon, or evening, depending on where you are.
Ladies and gentlemen, dear colleagues, welcome to a prostate cancer session. As you know, PSMA has revolutionarily changed the world of diagnostic and therapy of prostate cancer. And therefore, in this session, we have 3 talks only about PSMA. First, Dr. Aviral Singh is going to talk about the utility of PSMA PET in the diagnostic of prostate cancer. After that, I am going to present you the results of multicentric retrospective analysis of the data of more than 400 patients who got the therapy in 11 centers worldwide. The last speaker is Professor Richard Baum, who is going to talk about PSMA therapy. Enjoy the session.
Dear colleagues, I'm Aviral Singh from Central Clinic Bad Berka, and in this lecture, I will present the new European guidelines for the use of PSMA PET. I have no disclosures. PSMA PET is rapidly becoming a key player in the imaging of prostate cancer at various stages of the disease. Various forms of PSMA-based radiopharmaceuticals are in use and being researched for further use. As a disclaimer, the term PSMA PET in this lecture refers to gallium-68 and F18 labeled PSMA forms that have been widely used in clinical settings up to now. Joint guidelines for PSMA PET were published in 2017 and are the primary source for the standard operating protocols for PSMA PET worldwide. I will now discuss the joint European guidelines of the hereby stated clinical societies responsible for establishing the standards of prostate cancer management with reference to the role of PSMA PET and the key reference studies including herewith. The role of PSMA PET for initial staging of prostate cancer has not yet been established. For lymph node staging, CT, MRI, as well as choline PET-CT are still used. However, PSMA PET imaging is fast becoming popular in this setting, given that it has the added benefit of molecular imaging, complementing the morphological information provided by MRI, and hence improving the rate of successful biopsies as well. In intermediate to high-risk prostate cancer, it has a higher sensitivity and specificity compared to its morphological counterparts, even at very low PSA levels. Several studies have reported the high contrast to noise ratio of PSMA PET, which results in the higher detectability of pathological lesions. One of the widely cited systematic review and meta-analysis by Pereira et al. Demonstrated a high predictive ability of PSMA PET for primary staging, which was derived from 5 studies including histopathological correlation. The per lymph node analysis showed a pool sensitivity of 75% and a specificity of 99%. A recent prospective multi-center study in 103 intermediate to high-risk prostate cancer patients from the Netherlands demonstrated a per patient based sensitivity and specificity of over 40 and 90% respectively, resulting in treatment change for over 12% of the cohort of patients. The group from Innsbruck have reported on the correlation of higher PSMA uptake of the primary prostate tumor with PSA values higher than 10 nanogram per mil. The findings, however, of higher Gleason score with positivity on PSMA PET has not yet been widely reproducible. This recent meta-analysis from China of 13 studies comparing PSMA PET and MRI for primary staging and intermediate to high-risk prostate cancer patients prior to prostatectomy demonstrated a reasonably higher pool sensitivity of PSMA PET compared to that of MRI, with similar high specificities where PSMA PET was able to detect comparatively more lymph node metastasis. With regards to the staging of distant metastasis, bone scan and fluoride PET are still recommended for detection of bone metastasis, whereas choline PET and MRI have the additional advantage of detecting visceral metastasis. This prospective multi-center study from Australia demonstrated the significant impact of PSMA PET-CT in the setting of biochemical recurrence, with a remarkable change in the intent of management of over 60% of the evaluated patients. To summarize the evidence and practical considerations on initial nodal and distant metastasis staging, it can be concluded that PET imaging, particularly with PSMA and MRI, are more sensitive for the detection of both lymph node and bone metastasis in comparison to the classic workup of bone scan and CT. However, the clinical benefit of detecting metastasis at an earlier time point remains still unclear, given that the choice of systemic versus local aggressive therapies in such a setting remains unestablished. With regards to imaging in the clinical setting of persistently elevated PSA following radical prostatectomy, standard imaging with bone scan and MRI has a low detection rate for men with a PSA below 2 nanogram per mil. However, imaging with PSMA PET-CT has been shown to identify residual cancer with a positivity rate of 33% at PSA levels as low as less than 0.2 nanogram per mil, and at a rate of 97% in PSA levels higher than 2 nanogram per mil. This could also essentially guide salvage radiation therapy planning. In the context of elevated PSA after primary definitive therapy for prostate cancer, this German multi-center retrospective analysis in about equally distributed 130 men demonstrated that patients with a persistent PSA elevation had significantly more pelvic nodal involvement on PSMA PET-CT compared to those that developed a detectable PSA after the procedure of curative intent. Therefore, based on current evidence for the management of persistently elevated PSA after curative intent, PSMA PET is recommended for patients with a PSA level of over 0.2 nanogram per mil in order to exclude metastatic disease. This meta-analysis demonstrated a remarkably high sensitivity for detection of recurrent prostate disease, particularly at PSA level higher than 2 nanogram per mil, a comparatively high per lesion sensitivity and specificity, and higher PSMA positivity rates associated with a higher PSA velocity. However, the correlation of Gleason score with positivity on PSMA PET could not be established. The studies cited here have demonstrated that imaging with PSMA PET-CT in the setting of biochemical recurrence has shown comparatively higher sensitivity and specificity for the detection of pathological lesions, even at PSA levels lower than 1 nanogram per mil, which may eventually guide clinical management decisions in such patients. The detection rates of PSMA PET were significantly higher compared to that of choline PET-CT. This Australian prospective study comparing PSMA with choline PET-CT in the setting of biochemical recurrence demonstrated a significantly higher detection rate with a high overall impact on clinical management, again with PSA levels below 1 nanogram per mil. To summarize the role of imaging in case of biochemical recurrence, several studies have demonstrated that the higher sensitivity of PSMA PET compared to CT, bone scan, and choline PET-CT in the detection of distant metastasis. The early detection of metastasis in biochemical recurrence setting is clinically highly relevant after either radical prostatectomy or radiotherapy in order to optimize salvage treatment. Based on the current evidence in the setting of biochemical recurrence, PSMA PET is recommended both after radical prostatectomy when PSA is above 0.2 nanogram per mil as well as after radiotherapy in patients fit for curative salvage treatment. In the setting of non-metastatic castration-resistant prostate cancer patients, PSMA PET imaging is advised for patients who develop clinical symptoms irrespective of PSA levels, for the early diagnosis of castration resistance and optimizing further clinical management. PSMA-based radionuclide therapy has been newly included in the updated version of the EAU guidelines, and the use of PSMA PET imaging for patient selection is hereby indicated. Finally, in the scenario of non-curative or palliative treatments in a first-line setting, PSMA PET could be performed in patients with a persistently elevated PSA of over 0.2 nanogram per ml who have previously had a radical prostatectomy to guide further therapeutic interventions. Shortly to state the new developments since the publication of these guidelines, it must be noted that up to now there has been a lack of robust, prospectively conducted multicenter trials. And thus far, there is limited recommendation of the use of PSMA PET imaging in the initial staging of prostate cancer. Therefore, let's look at the new salient developments. This year, the results of the PRO-PSMA study were published in The Lancet. It is a prospective, diagnostic, phase 3, multicenter RCT evaluating the role of PSMA PET-CT before curative intent surgery or radiotherapy in patients with high-risk prostate cancer. About 300 patients were recruited and equally distributed to receive either PSMA PET-CT or the current standard of care with CT and bone scan prior to definitive therapy with curative intent. And the study demonstrated a superior diagnostic accuracy with fewer uncertain results, greater impact on treatment with consequent management change, and lower radiation exposure to the patients without any side effects in comparison to the current standard of care. In the wake of persistent newer data, studies, and increasing use of PSMA PET, consensus statements on PSMA PET response assessment criteria in prostate cancer have recently been published. Several aspects on the role of PSMA PET were discussed, and consensus was reached on all relevant issues. With regards to the use of PSMA PET-CT imaging, it can be used before and after any local or systemic treatment in patients at risk of having metastatic disease. However, it should not be used if no change of clinical management is expected, if local disease within the prostate is expected, in case of complete PSA response after salvage treatment of oligometastatic disease with curative intent. It should also not be used routinely in patients with hormone-sensitive prostate cancer, in case of PSA response under systemic therapy, and in patients with late-stage disease where no further therapies can be initiated. Regarding the appropriate timing of PSMA PET, in cases where the primary disease is negative on PSMA PET-CT, further staging with PSMA PET-CT is generally not adequate. If used for response assessment, then a baseline PSMA PET-CT should always be performed. It should not be performed within 3 months after initiation of systemic therapy in hormone-sensitive prostate cancer, in order to avoid detection of flare on imaging. It should also not be performed for routine follow-up with inconsequent management change. Ideally, PSMA PET-CT imaging criteria should categorize patients as responders or non-responders. Details of these definitions are provided in the publication. Response assessment of patients should ideally be performed in clinical trial settings and in clinical settings with inconsistent clinical or laboratory findings, or if change in clinical management is expected in real-world clinical scenario. Given the lack of comparative data, different gallium-68 and F18 radiolabeled PSMA tracers have largely shown similar performance. Importantly, for response assessment, the same PSMA PET tracer should be used. Meta-analysis and clinical trials on the subject of response assessment are encouraged. And to summarize, international guidelines, including the guideline of the European Association for Urology, have incorporated PSMA PET-CT and provide recommendation on its appropriate use. It is the consensus imaging modality in patients with biochemical recurrence or persistent PSA elevation after radical treatment with curative intent to confirm recurrent or metastatic disease. In other clinical situations, such as monitoring of treatment, PSMA PET-CT can be used before and after any local and systemic treatment in patients at risk of having metastatic disease. While for initial staging of high-risk patients, the ultimate role of PSMA PET-CT is still debated. In light of newer, emerging prospective research data, such as the recently published results of the PRO-PSMA study, changes to the current guidelines for the initial imaging of high-risk prostate cancer could be expected to change in the future. The use of PSMA PET-CT response assessment criteria should be implemented and further evaluated in the context of clinical trials. And with that, thank you for your kind attention.
Ladies and gentlemen, dear colleagues, I am Professor Ahmadzadehfar from Department of Nuclear Medicine, Klinikum Westfalen, Dortmund, Germany. In the next 15 minutes, I'm going to present you the results of the Worms multicenter study. As you know, several retrospective and a few phase 2 prospective studies with a limited number of patients have confirmed the efficacy and the low toxicity profile of lutetium PSMA therapy in patients with metastatic castration-resistant prostate cancer. It seems that lutetium PSMA therapy prolongs the overall survival, at least in patients with a positive response to this therapy. And the impact of prior therapies on the overall survival of these patients has been discussed controversially in different publications. All of these studies performed so far suffer from a limited number of patients and heterogeneity regarding prior therapies, and therefore Worms decided to plan a multi-center retrospective analysis to evaluate the response rate and the overall survival, as well as the impact of prior therapies on the overall survival in more than 300 patients treated with lutetium PSMA 617. Let me show you the inclusion criteria of this study. We included patients with documented progressive disease prior to the first cycle of lutetium PSMA therapy according to the PSA level and or PSMA imaging. All of the patients had to have a history of a therapy with abiraterone or enzalutamide, or both of them, or documented progressive disease under ongoing therapy with one of these agents. The primary objectives of this study were assessment of overall survival and its predictive parameters in these patients. The data of 631 patients were sent to us from 11 centers. After the first evaluation, we had to exclude the data of 215 patients because of missing survival data, and at the end, we analyzed the data of 416 patients. These patients got a total number of 1,493 cycles of lutetium PSMA therapy, a median of 3 cycles. As you see here, majority of the patients suffered from bone metastases, and about 20% of the patients had liver metastases. Majority of the patients had a good ECOG performance status of 0 or 1. As I mentioned before, all of the patients had to get at least abiraterone or enzalutamide prior to the lutetium PSMA therapy, and about 53% of the patients had had both agents. About 75% of the patients had the first-line chemotherapy with docetaxel, and from the patients who didn't get the chemotherapy, about 81% of these patients avoided to get the first-line chemotherapy. About 26% of the patients had the second-line chemotherapy with cabazitaxel, and of whom who didn't get a second-line chemotherapy, about 87% of the patients avoided to get a second-line chemotherapy. About 20% of the patients had a therapy with radium-223, median 6 cycles. Now the results of this study. The median overall survival in all of the patients was about 11 months. The response rate measured 2 months after the first cycle, as you see here, we had in 72% of the patients an any PSA decline, of whom about 42% showed a PSA decline more than 50%. Regarding the overall survival, according to the PSA decline, as you see here, patients with rising PSA 2 months after the first cycle showed significantly shorter overall survival compared to patients with a positive response to this therapy, independent from the percentile rate of PSA decline. As you see here, no significant differences between patients with a PSA decline less than 50% and more than 50%. Patients without the prior chemotherapy showed a significantly longer overall survival compared to patients with the prior chemotherapy. As you see here, about 15 months median overall survival in patients without the prior chemotherapy compared to about 10 months with the prior chemotherapy. Interestingly, between patients who didn't get the chemotherapy, we couldn't detect any significant differences between patients who didn't get the chemotherapy because they avoided it and patients for whom a chemotherapy was contraindicated. About 14 months in each group. Patients with bone metastases showed significantly shorter overall survival, 10.7 months compared to 25 months in patients with only lymph node metastases. And patients with liver metastases, these patients showed also significantly shorter overall survival compared to patients without any liver metastases, 6 months compared to about 13 months. ECOG status was also a significant prognosticator of overall survival. As you see here, patients with ECOG 0 showed significantly longer overall survival, about 16.9 months compared to patients with ECOG 1 and 2. Prior chemotherapy, ECOG status, and the existence of bone and liver metastases were prognosticators of overall survival in both univariate and multivariate analysis of this study. These data have been already published in European Journal of Nuclear Medicine and Molecular Imaging. Now, I would like to present the new results of the subgroup analysis of the 617 trial. In this retrospective multicentric study, we assessed the impact of the number of bone metastases on response and overall survival, as well as toxicity in metastatic castration-resistant prostate cancer patients. Of the 416 patients analyzed in the 617 trial, 319 patients had documented number of bone lesions ranging from no lesions to diffuse bone marrow involvement. We divided the patients according to Alisimka trial from no lesions to less than 6 lesions, 6 to 20 lesions, more than 20 lesions, and diffuse involvement. And you see here on the right side the percentile number of the patients in each group. Exactly like 617 trial, all of the patients got at least abiraterone or enzalutamide. About 76% of the patients had the first-line chemotherapy with docetaxel, 23% had the second-line chemotherapy with cabazitaxel, and about 24% of the patients got therapy with radium-223. Now let me present you the results of this study. The response rates. We couldn't find any significant correlation between the number of the lesions and the response rate. As an example here, between patients with increasing PSA level, you see here about 20 to 30% increasing level of PSA in each group. Also in patients with decline more than 50%, about 40 to 50% of the patients showed a PSA decline more than 50%, and therefore no correlation between the response rate and the number of the lesions. However, there was a negative correlation between the overall survival and the number of the lesions. Patients without any bone metastases showed the longest overall survival with 25 months compared to patients with bone lesions, especially with patients with diffuse involvement with about 8.2 months overall survival. Here you see the Kaplan-Meier curves of this analysis. We performed further analysis regarding existence of liver metastases. As you see here, in each subgroup, patients with liver metastases showed shorter overall survival compared to patients without liver metastases. For example, in patients with diffuse bone involvement, patients who got liver metastases showed 5.7 months overall survival compared to 9 months overall survival in patients without any liver lesions. And in all of these groups, these differences were significant. Regarding prior chemotherapy, patients who got a prior chemotherapy showed shorter overall survival in each group. However, these differences were only significant in one group, in the group with less than 6 bone lesions, 27.6 months overall survival compared to 14 months overall survival in patients with a history of chemotherapy. Interestingly, in patients who had radium therapy prior to lutetium PSMA therapy, in all of these groups, from less than 6 lesions to diffuse bone involvement, we had longer overall survival compared to patients who didn't get a therapy with radium. And these differences were significant in 2 subgroups, in the groups with 6 to 20 bony lesions and in the group with diffuse bony lesions. Here, for example, in the group with diffuse bony lesions, patients with a history of therapy with radium, they showed 11 months overall survival compared to only 7 months without any history of radium. Here you see the Kaplan-Meier curves of these 4 groups with a history of therapy with radium. Regarding the toxicity rate, we had significantly more anemia and more thrombocytopenia in patients with more than 20 lesions, bone metastases, and with diffuse bone involvement. As you see here, for example, grade 4 toxicity in about 5% of the patients, grade 4 anemia, and grade 4 thrombocytopenia in about 2 to 5% of the patients with more than 20 lesions. However, majority of patients also in the groups with more than 20 bony lesions showed no relevant hematotoxicity. Let me conclude the second part of my talk. Patients with higher extent of bone involvement showed the same response rate to the lutetium PSMA therapy as patients with lesser involvement. However, the overall survival of patients negatively correlated with the extent of bone involvement. The existence of liver metastasis was a significant negative prognosticator of overall survival in all subgroups. And it seems that the prior therapy with radium therapy had a positive impact on overall survival. Thank you very much for your attention.
Hello, everyone again. My name is Richard Baum. I'm speaking now about the topic of lutetium therapy in prostate cancer. It should be really named lutetium PSMA therapy in prostate cancer because there are other agents, for example, lutetium folate and other biphosphonates, which can be also used for treating osteoblastic metastases in prostate cancer. So radiomolecular precision oncology, or RPO, is the future of nuclear medicine and of cancer treatment, because cancers will be classified by genetic profiling and molecular phenotypes in the future. And this can be determined by molecular imaging using PET-CT and SPECT-CT. And I'm convinced that treatment will be targeted against the individual tumor of the patient, which is what we call precision oncology, and that nuclear medicine physicians will become the precision radio-oncologists. And I think that PSMA radioligand therapy is actually a very good paradigm for this approach, because we can determine PSMA expression of metastases by PSMA PET-CT before starting the treatment. Now, you all know that the established therapies like novel androgen inhibitors and especially chemotherapy with docetaxel and cabazitaxel only provide a survival benefit of 9 to 12 weeks for chemotherapy and of 3 to 5 months for second generation androgen deprivation therapy, or ADT. So there's an urgent need for a more effective therapy. And we can do that, of course, using lutetium PSMA radioligand therapy, or PRLT, especially in metastatic castration-resistant prostate cancer. And the treatment concept is shown here again. The first step is always to perform gallium-68 PSMA PET-CT to really prove that the patient has expression of our target. And then we should perform laboratory tests to assess bone marrow reserve, renal and hepatic function. We can also do technetium-MAC3 renal scintigraphy, especially if the patient has signs of malfunction of the kidney, and salivary gland scintigraphy, especially if we are going to use alpha emitters. Then we start treating the patient with the first cycle, and we monitor the patient under therapy for clinical symptoms, of course, also for biochemical response. And we can also use lutetium PSMA whole body scintigraphy and especially SPECT-CT, which provides very nice images. It's also important to assess possible adverse effects, of course, by following the labs, but also using standardized questionnaires. And then we perform the second cycle, and we can do restaging again with lutetium SPECT-CT under the treatment and already assess if there is a response to the treatment. And if there is an incomplete response, we can perform a third cycle. And we look again at the administered activity, which is given mostly as a standard dosage of about 9 for the first cycle or 7.5 gigabecquerel for the second cycle, or depending on each center's usage. And then if we are lucky enough, we can see in restaging that the patient has a complete molecular and morphological response as shown in this case here. Another issue is if we should perform dosimetry I think from a scientific point of view, it's very valuable if you are using novel radioligands to do that. And for example, we performed dosimetry here in a patient according to our Bad Berka protocol using lutetium PSMA 617. And you see that, that the bone metastasis here had actually a dose of 467 gray, and in follow-up it completely disappeared, as well as several other metastases. So we have published actually the first patient already in 2016 after we started in early 2013 using lutetium PSMA treatment. And when I left my previous center, we had performed over 1,300 treatments in most of the patients, 3 or 4 cycles, but sometimes also up to 11 cycles. And I can mention that we have now even given 14 cycles of lutetium treatment, sometimes even combined with actinium. For those who are interested on more details, there is a special feature of the British Journal of Radiology published end of 2018 on this topic. One clinical example in a patient with lymph node metastases, PSA of 4.6, resistant to hormonal therapy. So this patient was actually treated by external beam radiation therapy, and in addition by novel drugs like abiraterone. And unfortunately, after 1 year, the patient had widespread disease, though the lymph node metastasis in the abdomen had been in complete remission, but the patient needed a different treatment, and we performed lutetium PSMA 2 cycles in this patient. And fortunately enough, he had a complete remission of the disease, which with a PSA of 0.0 after the treatment. Now, if you look at this patient, you see the whole body lutetium scans here 20 hours and 70 hours after therapy. And you can recognize that even after a single therapy cycle, under the second therapy, there was already a complete remission of the metastases. So if we take PSA as a marker of response, we have seen any PSA decline in 70% of the patients, and in more than half of the patients, we observed a PSA decrease of over 50%. We have seen other patients with even complete regression of organ metastases, like in the lung, for example. And this is such an example where you can see that there were many lymph node metastases, but also a number of lung metastases before treatment. And after PSMA radioligand therapy with 8 and 8.2 gigabecquerel, there was complete remission of the metastases, and the patient is still alive in October this year. This case very nicely shows that there is not only a radiation effect, but also probably an immunotherapy effect, which is called by the lutetium PSMA therapy. Now you all know that chemotherapy is more like a bushfire. It destroys all of the bone marrow, whereas lutetium PSMA is a very molecular targeted, precise therapy, which can be also shown when looking at adverse effects. So if you look at this patient, one would expect, of course, bone marrow toxicity after treatment with over 175 millicurie. These are suspect CT scans of the patient showing that there is even involvement of the bone marrow under therapy. But if you follow the patient over a long time, you do not see any change of blood count or renal function. So there is no hematological toxicity and also no nephrotoxicity shown in this patient. If you compare that with a standard second-line chemotherapy, using Yestana or cabazitaxel, you see that, for example, there is neutropenia in 90% of the patients under this treatment, which is quite severe, namely grade 3 and 4 in 82% of the patients. Another fear of the oncologist and urologist is always the kidney, because the kidney is lighting up quite intensely on the gallium scans, as shown in this case, with a single functioning kidney on the right. The left kidney has been hydronephrotic due to blockage of the ureter caused by lymph node metastases. And you see that after treatment with lutetium PSMA, there is, first of all, nearly complete remission of the lymph node metastases. But more interestingly, there is a very nice improvement of kidney function of this single kidney, which you see in the steeper increase of the MAC3 curve and the more rapid excretion. And we have published this data in the journal, which enables you to also use lutetium in patients with a single kidney. I already mentioned that the survival benefit for chemotherapy and the novel ADT is quite limited. The same is true for radium-223. And the first study comparing prospectively lutetium PSMA 617 in patients with mCRPC was published in the Lancet Oncology by the group of Peter Mack. And you see that there was a very nice response in many patients. So it did not only work in our hand, but it also works in the hand of many others. And this was actually chosen as an image of the year in 2018. But what was also interestingly coming out from this trial was that they selected the patient also based on the FDG PET. So not only looking at the PSMA expression, but also looking at the FDG metabolism. And those patients having glycolytic metastases, like on the far left, with very poor PSMA expression, are not candidates for therapy, whereas those on the right with a so-called mismatch, where FDG is negative and PSMA is positive, are the ideal candidates for this kind of therapy. And if we go on here, you see that those patients who have not been treated by lutetium PSMA had a very poor survival. The median overall survival in this patient group was just 2.5 months as compared to the group treated with lutetium PSMA, which had an overall survival of 13.3 months. And it was even better for those who had a response of more than 50% PSA decrease, where it was 18.4 months. So what are prognostic markers? Not surprisingly, the metabolic volume, the glycolytic volume on FDG PET-CT is important. Of course, the PSMA intensity, which is inversely related, and also LDH and the alkaline phosphatase and the number of bone lesions are, according to this paper by Michael Hoffman, also prognostic factors. Now there is an ongoing trial, as you all know, which is a therapy trial, again headed by the group of the Peter Mack, comparing lutetium PSMA 617 with cabazitaxel. So up to 6 cycles of PSMA 617, and the results were just presented at this year's ASCO meeting. You see the primary endpoint was PSA response, defined by PSA reduction of over 50% from baseline and secondary endpoints were progression, PSA progression-free survival, and adverse effects. And just to show you that lutetium PSMA had a nearly 1/3 greater PSA 50% reduction as compared to cabazitaxel, and this also translated in a better outcome of the patients. And also lutetium was much safer than cabazitaxel, as shown in this table. So one can summarize that especially concerning efficacy, but also adverse effects, lutetium is superior to the cabazitaxel chemotherapy, and it offers potential, I would say, because of the data, you know, the same in many different centers in the world, not only a potential, but a very likely new class of effective therapy for mCRPC patients. The question is, should we be treating earlier? And our group was one actually of the first to ask this question, but there are now again prospective trials running. This is one patient, a 62-year-old internist who refused chemotherapy, and he presented in February 2016 with very severe pain due to metastases in the sacrum, and he had to give up his practice. And he did refuse chemotherapy because he had seen all the adverse effects in his wife. She unfortunately had been dying of breast cancer previously. So we treated him 3 times, and fortunately enough for the patient, he had a complete remission of the disease that was already in October 16. And then we followed the patient. He did not receive any other treatment except from lutetium PSMA. He could rstart his practice and playing tennis again. And we followed the patient July 17, also July 18, and August 2019 with complete remission of the disease. And he was here just a few weeks ago, which is now 6 years after the initial diagnosis and 56 months after start of PRNT. And we probably can state that we have cured the first patient with metastatic castration-resistant prostate cancer. Another question is if we should combine beta and alpha tandem or combo therapy. And we have shown in some patients that despite progression under lutetium radioligand therapy, there is still a response if you add a small amount of actinium-225 PSMA, in this case just 5 megabecquerel, and you still can get very good responses with the combined therapy. So for the future and advancing PSMA theranostics, and I very much thank Michael Hoffman for providing me with this slide, which is a very nice summary, what will be the future path for not only lutetium, but also for alpha emitters. So we have to look at different isotopes. As I mentioned, not only lutetium, but also actinium and probably Auger emitters like the terbium-161. We can then look at radiosensitizing agents. Here, for example, is mentioned the PARP inhibitor. We can look at the addition of hormones like ENSA, ABI, and apalutamide, which upregulate PSMA, as we know. We can look at combinations with immunotherapy, improving the starting dose, especially with predictive dosimetry, and looking at faster PET imaging and different, much longer-lived PET radioisotope, and finally at AI and radiomics. So I just want to show you one recent development at our center This is a patient who had progressive disease after lutetium PSMA treatment at a different center, including also condom therapy with actinium and lutetium PSMA. And then he presented at my new center in January 2020 before chemotherapy. And you see that there was quite a significant progression of the disease after 6 additional cycles of docetaxel chemotherapy, which was a complete failure. And we added BOT, which is benfoxythiamine, which is a thiamine B1 and agonist. And you can see the SPECT-CT images on the left, beginning of June, and the SPECT-CT images under the next treatment, end of July. There is a very good remission of the disease. So there are still new developments which are very encouraging, and I would like to summarize that PSMA-based radioligand therapy is really effective in end-stage disease. In some patients, we see tumor regression, even we can achieve complete remission in some patients. We have significant improvement of clinical symptoms, especially concerning pain from bone metastases, and we can prolong progression-free survival, as we have already published in 2016, and very likely also we have a substantial survival benefit, especially in those patients where we start the treatment earlier. We have excellent tolerability in nearly all patients treated with no or minimal hematological toxicity, especially in chemotherapy naive patients. We do not see any nephrotoxicity, and we can, with lutetium, see only low rates of persistent salivary gland toxicity. And this is the future perspective. If you can show that again, please. Combination of lutetium and actinium as tandem or alpha radiation therapy seems to be very promising. You will hear about that also in the following presentations. Genetic signatures and radiosensitizers are key research components. We will have new therapeutic radioisotopes in combination with other treatments. And I'm very much looking forward to the results of prospective clinical trials, which will hopefully be finished beginning of next year. Thank you very much for your attention, and have a nice ongoing virtual meeting. Thank you very much.